My low point probably came in some of the conversations where my wife was expressing how unsatisfied she was with our sex life.
I felt like I had failed in being intimate, and it was devastating.
He was desperate to find something, a cure.
It was really embarrassing for me to where a lot of times I just, I gave up.
Erectile dysfunction affects the psyche of a man more than anything else.
People think that they're the only one, that they're alone, that there might not be a solution for their problem.
52% of men between the ages of 40 and 70 have some degree of erectile dysfunction.
ED is the tip of an iceberg. It translates into all aspects of their life. So it's our duty to raise awareness, demystify, educate about a solution that may be the single best treatment option beyond the pill.
If you could put yourself in my shoes and say, what was it like? And then change it.
Maybe we wouldn't have wasted so many years.
The reality is you can fix erectile dysfunction and you can have a life, a good life.
All right. Hi, everyone. How are you? So as Malia said, I'm going to be talking tonight about erectile dysfunction and male stress urinary incontinence. My name is Matthew Sterling. Some of you might already know me. I am at MidLantic Urology in Bryn Mawr. Just briefly about myself, I grew up in South Jersey. I went to Penn State. I am, for those that know me, a crazy Penn State football fan. Went back to New Jersey for my medical training. I did my urology residency at Penn and then did a fellowship in reconstructive urology and prosthetics at Temple University. So I've always been around the area. Today, we're going to talk about first erectile dysfunction and then stress incontinence. So erectile dysfunction is defined as the persistent inability to achieve or maintain an erection enough to perform sexual intercourse. And why we're here is because it's so common. So 20% of men over 20 and more than 50% of men over 40 have some sort of erectile dysfunction and seek treatment. It has a significant psychological effect. I mean, I see patients all day about erectile dysfunction. Patients really have anxiety, depression, lower self-esteem, and it really decreases patients' quality of life. I think it's really important to understand how things work correctly so we can better understand what happens when they don't work correctly. And so the normal erectile process is with arousal, the nerves around the penis become activated, the muscles around the blood vessels relax, and more blood flow comes into the penis. As the penis fills, it stiffens, and the erection will then compress the veins so blood can't leave the penis, enabling patients to maintain a normal erection. It is associated with age, smoking, vascular or cardiovascular disease, diabetes, and various medications, amongst the other lists that you can see here. ED and heart disease is very closely linked. So symptoms of heart disease may develop within 2 to 3 years of ED. And the reason for that is the blood vessels supplying erections are much smaller than the blood vessels supplying patients' hearts. And it's often a sign of more cardiovascular disease. And so again, ED itself is a risk factor for future heart disease. So anyone that sees me for erectile dysfunction, I make sure they have a primary care physician that they see to check their blood pressure, diabetes checked, cholesterol. It's really important in preventing more progression of their erectile dysfunction. And the severity of erectile dysfunction is very closely related to the severity of heart disease. And it can precede a coronary artery disease or a coronary artery event in almost 70% of patients. ED is often very closely linked to prostate cancer, as many of you might know. With nerve-sparing prostate procedures, some men may regain more normal function. But the reality is the nerves and the blood vessels that supply the penis can become damaged or injured during surgery just as part of the normal surgical process. Nothing that the surgeon did incorrectly. It's just, again, the nerves are very close to where the prostate is. And about anywhere from 25 to 75% of patients can have permanent erectile dysfunction after this procedure. As you can see here, the prostate sits between the bladder and the penis, and the nerves that supply the penis for erectile dysfunction go next to the prostate. So sometimes nerve sparing can't even be performed, but even if a nerve sparing is performed, as you can tell, with removal of the prostate, it's very common to have injury to some of those nerves supplying erections. Erectile dysfunction is often associated with low testosterone, so I will almost always check a testosterone level in patients that see me for erectile dysfunction. It's more common as you get older. The testicles just don't produce testosterone like they used to, and can be associated with more chronic illnesses, obesity, diabetes, sleep apnea, and other conditions. Some of the symptoms of low testosterone are really non-specific. So patients will come and see me and saying they're having more fatigue or mood changes. It doesn't necessarily mean they have low testosterone, but that can often be associated. So lower libido or sex drive, erectile dysfunction, changes in their body hair, potentially hot flashes, depression, mood issues. These are all common symptoms associated with low testosterone. There's a lot of different forms of therapy now. We have injection therapy that people do on their own at home once a week. We have pills, there's gels, and there's implantable pellets that I can put under the skin. And I do that about every 4 to 6 months. So there's a lot of options for patients with low testosterone. So what are some of the treatment options specifically for erectile dysfunction? So the first thing is who treats it. So oftentimes a general practitioner or family doctor is going to start the treatment with either Viagra or Cialis. In patients that fail, they'll come and see a urologist. This is obviously a doctor specialized in training and focusing on the male and female urinary system and the male reproductive organs. In patients that have more advanced erectile dysfunction, they're often referred to a subspecialist or a prosthetic urologist, such as myself, that has additional fellowship training to treat these types of disorders. For patients that know me already, I often start with the least invasive or the most conservative options first, and then move along the path until potentially a surgical option. So first, I'll always talk about lifestyle changes. So eating well, exercising, losing weight, stopping smoking, getting good sleep. More than 6 to 7 hours of sleep can be associated with improvements in erectile dysfunction, and taking steps, obviously, to reduce stress. These are all really important things that can improve testosterone levels and improve patients' erectile function. Mental health support is really important. So a lot of patients will have, I'll send to a sex therapist because there's a lot of psychogenic components to erectile dysfunction, a lot of stress associated with it. So I'll often send people there in addition to treating their erectile dysfunction. Oral medications everybody knows about. So Viagra, Cialis, Levitra, and a newer agent, Stendra. These are called PDE5 inhibitors. And how they work is they further relax the blood vessels and improving blood flow to the penis. And this is typically the first thing I'll try for patients. And a lot of patients, it really works. Some patients, it doesn't. And some of the side effects can be headache, lightheadedness, facial flushing, upset stomach. It's really important before starting these medications to actually see a doctor. I know there's a lot of online places where you can just go get medications without seeing a doctor, but there are some limitations and restrictions that you just need to be aware. So it's really important, I think, that you see either a primary or a urologist to get these medications, just to make sure that you're doing it safely. For some patients, I'll recommend a vacuum device. I would say I don't, in my practice, typically recommend this that much just because the success rates are about 30 to 40%. So it's not as successful as some of the other treatments that I offer. How it works basically is a tube is placed over the penis and it creates a vacuum pulling blood into the penis. Once an erection is achieved, we put a ring over the base of the penis to help patients maintain their erection. I often tell patients the penis might look blue or bruised, can cause some discomfort. It can be more of a cold or a numb penis. And so this is something I talk to patients about beforehand and why I tend not to recommend a vacuum device quite as much. Intracavernosal injections is usually where I'll go next beyond pills. So if patients aren't doing well with oral therapy, I'll often talk about injection therapy or potentially surgery at that point. And basically, we would teach you how to do this. The needle is used to inject the medication directly into the penis, really increasing blood flow to that area. It has about an 80 to 90% success rate. We do worry about 5% of patients can have a prolonged erection. So it's something we talk to everyone about. About 5 to 10% of patients can develop scar tissue or curvature to the penis. And a small percentage of patients can have pain or a little blood bleed or a hematoma under the skin. The most common reasons people stop is it just doesn't work. So there's a lot of different options. I can taper people up on the medication, but it still might not work. Or inconvenient. So it has to be in the refrigerator or the freezer. So if patients are going on vacation, it can be more challenging. And then also might not be cost effective depending how much patients are injecting. And then I'll usually talk about implant surgery. So this is a device that's implanted into the penis, intended to allow a man to have an erection in those with erectile dysfunction. It's entirely within the body. No one is really able to see it, and no one would know that it's there except for you. And it's controlled by the user to achieve an erection. It's designed really to allow for a spontaneous erection when patients want, and for as long as patients want. And we can go through some of the nuances in terms of complications afterwards. There's two different types of implants. There's a 3-piece or an inflatable, which is the most common implant that I'd say I place. And then there's a Tactra or a 2-piece malleable penile implant for a very specific population of patients. The 3-piece inflatable penile implant really has 3 design options, which is the most variation in the market, which is why, again, I really like Boston Scientific products. It's coated with inhibizone, which is an antibiotic to prevent infections, which is really important in this surgery. It can closely mimic a more natural erection, provides rigidity when inflated. So you'll see on a video, but basically there's a pump within the scrotum. There are 2 cylinders within the penis and then a reservoir of fluid within the abdomen. And so when patients are ready to have an erection, they squeeze this pump and fluid goes into the cylinders and you get a really natural, nice, firm erection. And when you're done, you squeeze another little button and it deflates. The other thing that's great about this implant, it's been around for more than 50 years. So patients that think this is a new, novel idea, it's really not. It's been around for a while. There's been hundreds of thousands of implants placed. So just a brief video. I'm going to skip ahead slightly. So again, you see a patient squeezing this pump. Fluid is going from the reservoir into the cylinders to create, again, a nice firm erection. All this is on the inside. So it feels, again, more like a pretty natural erection. And then patients will squeeze the button and the fluid will leave, go back into the reservoir and deflate. So I make a incision in the scrotum. Procedure is performed in the hospital under general anesthesia. Typically, patients will stay with me overnight, one night in the hospital, although some can do as an outpatient. I tell patients you're going to be a little bit sore for the first few weeks, a little bit swollen. And then after that, patients will start increasing their activity. And most patients are using this by 4 to 6 weeks after surgery. The best thing about this surgery is very high satisfaction rate. So 95% of patients are satisfied with their intercourse with this, as well as their partners, which is really important. And more than 95% of patients would recommend a penile implant to a friend. So again, they're happy that they did this. You might not be able to hear this. We'll have a patient come on and talk about it in a little bit. I'm not paid to do this by Boston Scientific. I like the Boston Scientific products. They have both erectile dysfunction and incontinence products. And I've really had a good relationship with them since I was an early resident. So it's been a long-term relationship. Again, we reviewed some of this. So it's a proven treatment for advanced erectile dysfunction, a very high satisfaction rate. Most patients would recommend this to a friend that they've already had surgery. It is typically covered by insurance, although I can't guarantee that. Obviously, there's a million different types of insurance out there, but most commercial insurances, Medicare, do cover it. Obviously, it's reliable. It's designed, again, for a more long-term solution for ED, and it's natural. It's entirely within the body. And again, only you have to know that you have this. Every surgery has risks. Again, for patients that know me, I sit down with you, I give you a packet, we review all the benefits, all the potential risks. And that's really important when you're getting involved in any surgery, that your surgeon sits with you, goes through all the benefits, alternatives, and risks. It's really important. Some of the more common risks. So you can't go to an implant and then go backwards, which is, again, I typically take a graduated approach. So once you do that, you can't then go back and try injection therapy. You can have device malfunction in a small percentage of patients. We always worry about infection. With this implant, is a very low infection rate of about 1 to 2%. Again, typically covered by most insurance plans and Medicare. And this is a really good website to let more information about treatments for erectile dysfunction. And I'm going to leave this on for just a brief second if patients want to scan a QR code. All right. So we're going to switch gears a little bit to topic near and dear to my heart, male stress urinary incontinence. So what is it? So stress incontinence happens with anything that increases pressure or activity on the bladder, causing a patient to leak, such as coughing, laughing, lifting, or physical activity. It's actually more common than people would think. About 17,000 new men each year have stress urinary incontinence. Again, to understand how things work, or how things malfunction, it's important to understand how things work. So the bladder holds urine. Patients then urinate through the prostate out of the urethra. And what starts that is this muscle that sits close to the prostate called the external urinary sphincter. And relaxing that muscle starts the process. The muscle is always typically closed, and so patients don't usually leak. Prostate cancer surgery, such as removal of the prostate in conjunction with radiation therapy, basically what that does is it weakens that muscle. And so anything that can put more pressure on that area can cause leakage. And the weaker the muscle is, the more patients are going to leak. Benign prostate surgery, such as a TURP, neurogenic conditions, pelvic surgery, urethral surgery, can all be associated with urinary leakage, again, due to a weakening of that muscle. It has a significant impact on patients' quality of life. I can tell you when patients leak, they're really unhappy, associated with depression. It's really important, again, to see someone that knows what they're doing when it comes to urinary incontinence. So stress incontinence and prostate cancer treatment. So prostate cancer is an extremely common disorder. Prostate surgery is really common, almost 100,000 prostate surgeries a year. And about 10 to 15% of patients are going to have persistent leakage after a year, 1 year after treatment. So this is a pretty high number considering how many patients actually have surgery. Again, removal of the prostate can cause weakening of the muscle that sits right here, and that can result in urinary leakage if the pressure is not there to counter some of the pressure from the bladder. So what are some treatment options? So the first thing I always will talk to patients about is behavioral changes. So drinking less fluid, timed voiding. I talk about pelvic floor physical therapy in those with mild leakage, so wearing 1 to 2 pads a day. Leakage beyond that typically is not going to improve with pelvic floor physical therapy, although patients can often try that first if they want to. Obviously, patients are going to be wearing pads or diapers. I will talk to some patients about a penile clamp or catheters, but typically these are only patients that I'm not quite sure what's going on, or they're not candidates for surgery. There's 2 surgical options that work for patients: an advanced sling and an artificial urinary sphincter. So I'll talk about both. A sling is for mild to moderate stress incontinence, not typically associated with radiation, typically associated with prostate cancer surgery. It's a more minimally invasive procedure, and patients are able to pee just like they would otherwise would. And about 70 to 80% of patients are going to have a significant reduction in their pad usage. The sling essentially serves as a hammock or a support for the urethra, again, to help restore a normal bladder control. And again, about 90% of patients are going to recommend this to a friend who have had this surgery to just show the satisfaction rate with this procedure. An artificial urinary sphincter is really the gold standard for stress urinary incontinence and is designed to treat male patients after prostate surgery and can treat all levels of incontinence, not just mild to moderate, but even severe stress incontinence. It's discreetly within the body and can restore the process of urinary control and mimics the function of the healthy urinary sphincter. So basically it has 3 components. There's a cuff that sits around the urethra, again, mimicking that sphincter. There's a pump within the scrotum, and there's a reservoir within the abdomen, and this is filled with fluid. And so when patients feel like they have to urinate, they squeeze this pump, fluid will then leave the cuff, it'll open up, patients will be able to urinate, and after about 90 to 120 seconds, it closes on its own, and patients can restore their continence again. And again, here's a short video showing how this works. So when a patient has to urinate, they'll squeeze this button once or twice. The cuff opens, urine will then leave, and after about 90 seconds, the cuff closes on its own. So this is typically can be performed as an outpatient procedure. I'll oftentimes keep patients overnight 1 night, small incisions. Most patients are a little sore or swollen for a week or 2, and then returning to fairly normal activity. And about 6 weeks after surgery, we'll activate the device and patients will start to use it for the majority of patients. I will tell patients that my happiest patients are those that have undergone surgery for their stress incontinence, because it's such a quality of life problem when patients leak. And then when they're dry, they are really the happiest patients that I see. More than 90% of patients are satisfied with this procedure, and more than 90% of patients would recommend it to a friend. So again, similar to a penile implant, these surgeries are typically covered by Medicare and most commercial insurance plan. Obviously, coverages vary. So when we're planning for surgery, you can obviously discuss with our billers or your insurance what your coverage really is going to be. So obviously, what are the benefits of these treatments? Obviously, they can help you achieve your bladder control. You can urinate when you want to, and you're not just leaking all the time. It's entirely inside the body, has a very high satisfaction rate, and it really helps patients restore more normalcy to their lives. I have some patients now they can go on vacation, now they can go out to dinner, now they can kind of live their lives as they were more intended to live. Obviously, again, every surgery has risks. For the patients that know me, I sit down with you, I review these risks in a lot of detail. Just some briefly, you can have obviously failure of the device. Patients can have trouble urinating afterwards, requiring a catheter for a short period. Patients will often have pain for the first week or two. Again, not typically beyond that. It's possible to have infection. The risk of that is about 1% to 2%, so it's very low. And then cuff-related issues. So a summary, stress incontinence is a known side effect of prostate cancer treatment and potentially BPH or benign prostate treatments. There's a lot of treatment options. There's really two main surgical options, a sling and an artificial urinary sphincter. Injection therapy really doesn't work that well. I will often see patients that have had that and failed and want something more definitive. It's really important to speak with a urologist as well as, again, a reconstructive urologist that has specialty training in this area. It's really important. Again, here's a QR code. Patients that want to click that, I'll leave that up for 10 to 15 more seconds. And we're going to turn it over to Ron, who's a patient. And then patients can ask questions. And honestly, it's open forum. I'm happy to answer any questions that you have. I hope you found this informative.